This lecture provides an introduction to environmental health and lays the foundation for the rest of the course. We'll define environmental health, the 10 essential environmental health services, introduce how we identify and prioritize environmental health issues, risk assessment, and the toxicological paradigm, which is a model for conceptualizing how environmental exposures can cause disease. But before we get into talking about environmental health, what do we mean by environment?
There's the natural environment, also known as nature. Then there's the built environment, which includes all settings that have been created or modified by humans, including houses, roads, and farms. There's also the social environment, created by interactions between humans, including culture, economic conditions, and institutions like universities. The conditions of the environments where we live, work, and play have important consequences for our health. Clean air, land, and water are important, but some communities are more exposed than others to environmental health hazards, and those differences contribute to health disparities that environmental health professionals work to reduce. Uri Bronfenbrenner recognized that human health is shaped by multiple interconnected layers surrounding an individual: the microsystem, mesosystem, and exosystem. His theory argues that the environment you grow up in affects every facet of your life. Health is impacted by the interactions between all these levels of the system surrounding a person. At the center of the socioecological model is the individual, their genetics and behaviors. Surrounding them are family members, friends, schools, and workplaces. Beyond that are neighborhoods, communities, transportation systems, housing, local policies, and then larger societal factors like government, economic systems, and culture. Factors external to an individual at all these levels interact to influence health outcomes. For example, a child born in Baltimore in 1990 lived in a row home built in 1920, with many layers of paint applied to the windowsills before residential lead paint was banned in 1978. Many decades later, that paint was flaking as his family opened and closed the windows, and like many toddlers, he put the lead-containing paint chips, which have a sweet taste, in his mouth. When he got older, he played in the yard where the soil was contaminated with lead that had accumulated from decades of leaded gasoline emissions before leaded gas was phased out, starting with the Clean Air Act in 1970 and banned completely by the EPA in 1996. Childhood lead exposure can impair neurodevelopment, lower IQ, affect attention and executive function, and increase the risk of learning disabilities and behavioral problems. The boy struggled in school, and this contributed to his not completing high school. He got his first job at Bethlehem Steel, but the plant soon closed as manufacturing jobs continued to move overseas. Limited educational opportunities and the loss of stable employment reduced his economic opportunities and caused chronic stress in adulthood, which, combined with other social and environmental factors, contributed to his development of cardiovascular disease in his 40s. In contrast, a girl born in Anchorage the same year lived in a house built in 1987, so she was never exposed to lead paint. Because of the relatively low population density and lack of traffic, the soil in her yard wasn't contaminated with lead from gasoline emissions over previous decades. These cases illustrate how different levels of the socioecological model interact to shape a person's health. Community and institutional factors, including schools, workplaces, housing quality, and neighborhood conditions, economic forces like the decline of the U.S. steel industry and loss of manufacturing jobs, shape employment opportunities and financial security, which in turn also influences health. Neither child had any control over whether lead was in paint or gasoline before they were born, but they experienced the downstream consequences of policy decisions made decades earlier. This is what we mean by upstream determinants of health, decisions made at the population level that influence the health of individuals within the population for generations. Environmental health seeks to change environments so harmful exposures are prevented and healthy choices become the default rather than the exception. A determinant is any factor which could be an event or characteristic that brings about a change in health. Determinants of health can be physical, such as genetics, or environmental factors external to the individual. Two individuals with the same genetic risk can experience different health outcomes if one has access to clean air, nutritious food, stable housing, and high-quality health care, while the other does not. The obesity prevalence among public elementary school age children in the district where you work is nearly double that of a network of private schools in the area. List at least 3 factors at the individual level and 3 environmental factors you would want to gather more data on to study what may be causing this difference between the local school systems. Some examples at the individual level would be whether the particular child plays sports, whether they have asthma or other medical conditions, which foods they individually choose to eat, whether they drink soda or other sugar-sweetened beverages, and at the environmental level, whether the kids can safely walk or bike to school, if the local air quality is safe to allow them to play outside, and what foods the school provides for the children. Thinking about the socioecological model, you can see how many things we could say are choices at the individual level are strongly influenced by environmental conditions. If you're a child and all your peers are eating French fries and drinking soda, it would be very difficult to be the one kid who brought carrots from home as their snack. Similarly, if the school has lots of soda vending machines, it might make sugar-sweetened beverages the default, which increases the risk of obesity compared to if kids are drinking water. This distinction between what's caused by the environment and what's more about individual choice isn't always important to make, but it can be helpful to guide interventions. If something is mostly about an individual decision, like if one kid brings a big gulp of soda to school every day while all the other kids drink water, that wouldn't benefit much if we did an intervention on the population level, like removing vending machines. If we want to help that one kid, it would make a lot more sense to intervene at the individual level, like with nutrition counseling for him and the adults in his household. On the other hand, if a lot of the kids are smoking cigarettes and there's a store next door to the school selling them without caring how old people are, and recess isn't supervised, so it became a de facto smoke break, in this case, intervening at the population level would be much more helpful. We wouldn't fix the problem by sitting each kid down and doing smoking cessation counseling. We need to figure out how to stop the sale of cigarettes to minors, so we'd likely get law enforcement and local government involved, the Chamber of Commerce if they have one, and we need to figure out how to supervise campus better. Maybe hire a security guard who can round up smoking kids and bring them to detention. Many possible options. But interventions would target the whole population of students, not individuals if there's environmental factors driving smoking. So what is environmental health? One of the early widely accepted definitions from the World Health Organization in 1986 is environmental health is a branch of public health concerned with the direct pathological effects of chemical, physical, and biological agents and of the effects of the broad physical and social environment on human health. Environmental health traditionally focused on exposures to toxic substances, but even this definition is broader than the health effects of air, water, and soil. More recent definitions have trended broader still to include factors in the social and cultural environments. The Institute of Medicine expanded on this perspective, defining environmental health as the human health impact of the holistic environment, one comprised of the natural, built, and social environments. In 1999, the World Health Organization updated that environmental health addresses all the physical, chemical, and biological factors external to a person and all the related factors impacting behaviors. It encompasses the assessment and control of those environmental factors that can potentially affect health. It's targeted towards preventing disease and creating health-supportive environments. Environmental health focuses on reducing the negative impacts of unsafe environmental conditions, like polluted air and water, on people in order to decrease preventable illness and injury. Note that in these traditional definitions, environmental health is about creating an environment that's safe for people and reducing the risk of harm to people from hazards in the environment. Whereas environmentalism was the term for efforts to reduce the harm people were doing to the natural environment. The American Public Health Association defines environmental health as the relationships between people and their environment. When people are exposed to hazards like polluted air and lead in their drinking water, they can develop serious conditions such as asthma, heart disease, cancer, and dementia. It goes on to say, Black, Indigenous, people of color, and low-wealth communities are disproportionately burdened by environmental health hazards, systemic and structural racism and disinvestment, negatively impacting their health and well-being. The environmental health field advances policies and programs that reduce chemical and other environmental exposures in air, water, soil, and food. A key part of any comprehensive public health system, environmental health ensures everyone has a safe place to live, learn, work, and play. This definition removes the directionality, so it isn't just about what the environment does to humans, but it doesn't go as far as One Health, which is the recognition that the health of human populations, animal populations, and the environment are interrelated and interdependent. The 10 essential public health services are the overarching responsibilities of public health. The essential services provide the framework and roadmap for public health, whereas the public health process provides the specific day-to-day methodologies used to deliver them. Whether investigating contaminated drinking water, inspecting restaurants, monitoring air quality, or responding to disease outbreaks, all these jobs work to meet the essential public health functions. Everything we do in public health is essentially about understanding and controlling risk. Risk assessment focuses on understanding the probability that an exposure will cause harm. It draws on many disciplines, including toxicology, epidemiology, environmental monitoring, pathophysiology, and pharmacology. Risk management involves selecting the most appropriate interventions to reduce risk based on the results of risk assessment, along with social, economic, and political concerns. Most of this lecture focuses on understanding risk. Later in the course, we'll shift towards how that knowledge is translated into policies and interventions that mitigate risk. The public health process provides a systematic framework for addressing population health problems. Assessment is always the first step. Once an issue is identified, we quantify it using surveillance and epidemiologic data to describe its magnitude, distribution, and determinants. Then we review scientific literature and engage stakeholders to identify evidence-based and community-informed interventions. After selecting and implementing a program or policy, we evaluate its effectiveness using predefined outcome measures. By following these steps, we aim to improve population health, reduce health disparities, and ensure that interventions are driven by evidence rather than special interests or politics alone. As with other public health disciplines, environmental health and healthcare share the common goal of improving health, but they differ fundamentally in their level of focus. Thinking about health at the population level can seem abstract. To draw parallels between the healthcare of an individual patient and that of a population, let's look at how we evaluate health at both levels. We can measure the health status of a population by looking at life expectancy or mortality. By comparison, for an individual, we can evaluate health status by measuring someone's blood pressure. We can measure the impact of a disease on a population by looking at health indicators like incidence rates or disability-adjusted life years. For an individual, we might assess the impact of a disease by looking at their symptom progression. We use health indicators at the beginning of the public health process when deciding what to prioritize, then we use them at the end to evaluate whether the intervention is working. Population health indicators help identify where environmental health interventions are likely to have the greatest impact on population health. Incidence and prevalence are health indicators you'll learn more about when you take epidemiology, but briefly, incidence is the number of new cases out of the people at risk, while prevalence is the number of cases present in the population out of the total number of people in the population. Prevalence is the proportion of the population who has a particular disease. As new cases occur in the population, represented here by the wine bottle pouring more liquid into the top of the container, they become prevalent cases. When people with the disease are cured or die, represented here by getting poured out into a glass, they cause the total volume to decrease, so the prevalence decreases. If new cases of the disease are occurring at the same rate at which people are either dying or being cured, the prevalence will remain the same. If a disease has a long duration, it tends to result in a higher prevalence because there's more people with the disease in the population. For example, most people have type 2 diabetes for many years, so after they get diagnosed, they're a prevalent case in the population for many decades. But a disease with a short duration, like the common cold, may have a very high incidence because it's common, many cases occur, but it would have a lower prevalence in relation to the incidence because you don't have the common cold for very long. Which of the following explains the trends in disease X in the United States population? The only answer that fits is that the population's exposure to an environmental contaminant has increased over time, leading to more new cases of disease X each year, because incidence is increasing while prevalence is remaining relatively stable. This means more new cases are occurring, but the disease duration hasn't increased. I mentioned previously that we're almost always dealing with finite resources in environmental health, so what criteria should be used to identify what constitutes an important environmental health issue? One approach is to look at population attributable risk, which is a measure of association used to estimate the effect of an exposure on the occurrence of the disease. It's the proportion of the incidence of a disease in the population, both the exposed and unexposed, that's due to that exposure. You don't need to memorize this equation. I just want you to understand the concept here. Population attributable risk is driven by two things: the relative risk of that exposure or activity. The higher the relative risk is, all else being equal, the higher the population attributable risk will be, which makes sense. And the second thing that drives population attributable risk is the proportion of the population exposed. Another way to think about population attributable risk is it's the incidence of a disease or outcome in the population that would be eliminated if a particular exposure were eliminated. Let's say the relative risk of unintentional death is 1.5 for driving a car, and 1,000 people in the town where you work for the health department drive cars. And only one person in your town is into base jumping, but the relative risk for base jumping is 15. If a much greater proportion of the population in your town is exposed to driving, even though the relative risk is much lower, the population attributable risk will still be higher. The Clean Air Act, the main federal air quality law in the U.S., signed by President Lyndon B. Johnson in 1963, regulates two broad categories of air pollutants: hazardous air pollutants and criteria air pollutants, which there are 6 of. There are almost 200 hazardous air pollutants. So why do the criteria air pollutants get their own category? They pose a greater population attributable risk, even though they're less harmful to human health, because they're ubiquitous. The criteria air pollutants don't stay in the air locally at the source emitting them. They spread everywhere. So the percentage of the population exposed to the criteria air pollutants is much greater than the percentage exposed to the hazardous air pollutants. In environmental health, we're thinking about both the risk posed by an exposure and how many people in the population are exposed. Whether you work for a local government or a large company, every organization operates with finite resources. No organization has the capacity to address every environmental threat. So, how do we prioritize which issues limited resources should be allocated to? These decisions need to consider both what the most important problems are currently and also what direction the problems are trending in. Environmental health aims to improve conditions at the population level by creating healthier physical, social, and built environments. Rather than focusing on why one individual became sick, we ask why certain populations consistently experience worse health outcomes and what environmental changes might reduce those disparities and prevent disease or injury from occurring. Before we can prevent injury or illness, we need to first understand how and why it happens. Health results from the interaction of individual factors like genetics and behaviors like exercise and smoking, environmental factors including exposures like to secondhand smoke, which interacts with age and time. Thinking about how factors at various levels around a person influence health guides development of interventions, which can be at the individual, interpersonal, organizational, community, or policy level. Risk assessment provides the framework for evaluating whether an environmental exposure is likely to cause harm. The process has 4 steps: hazard identification, dose response assessment, exposure assessment, and risk characterization. Risk assessment involves clinical, epidemiologic, toxicologic, and environmental data, which is integrated to support risk management decisions and guide public policy. The first step in risk assessment is hazard identification. The objective is to examine the evidence linking an exposure and health effects to determine whether the agent is capable of causing the health outcome. Hazards may be chemical, physical, biologic, ergonomic, or social or psychological. Once a hazard has been identified, the next step is dose response assessment, which measures the relationship between the amount or magnitude of exposure and the likelihood or severity of adverse health effects. Many substances are harmless at low doses but become toxic above a certain threshold, while others, such as ionizing radiation, carry some risk even at low doses. Dose-response relationships have traditionally been established through animal studies, but recent technological advances have allowed researchers to transition away from reliance on lab animals by using human cell lines or tissue models and computer models and machine learning to predict toxicity in humans based on a chemical's molecular structure. Why does one individual, when exposed to a toxicant, develop disease, while another with the same exposure does not? The health effects of an exposure depend on more than the dose. Duration of exposure, frequency, route of exposure, age, genetics, underlying medical conditions, and concurrent exposures all influence individual risk. Exposure assessment measures the relationship between the amount of exposure and the occurrence of the unwanted health effects. It examines the quantitative relationship between an experimentally administered dose of a toxicant and the response in lab animals, or alternatives like computer models, and draws inferences for humans. Risk assessment concludes with risk characterization, which integrates hazard, dose response, and exposure data from the previous three steps to estimate the likelihood and magnitude of adverse health effects. Risk characterization also summarizes uncertainties and assumptions in the available evidence. Environmental health decisions are often made before complete information is available, so communicating uncertainty is an essential part of the process. Risk characterization provides information for decision makers used as the basis for policies to mitigate risk. Understanding the mechanism by which people are exposed to a hazard is important for understanding the health impact and for designing interventions to mitigate risk. Routes of exposure include cutaneous or dermal, when an agent comes in contact with the skin, percutaneous, when a contaminated sharp object such as a needle punctures the skin, inhalation, when airborne agents such as gases enter the body through the respiratory tract, and ingestion, when agents in food or water are swallowed and enter the body through the gastrointestinal tract. Identifying the primary route of exposure helps determine both the health risks and the most effective intervention. For example, improving ventilation reduces inhalation exposures, whereas water treatment reduces ingestion exposures. A single agent may have multiple exposure pathways. For example, botulism, a toxin produced by the bacteria Clostridium botulinum, which lives in soil in many areas, can be ingested by eating improperly canned food. Or if an overdose of Botox is injected, muscle weakness may spread beyond the intended treatment area, potentially causing inability to swallow or inability to breathe in extreme cases. In addition to people injecting botulism toxin into their faces on purpose to reduce wrinkles, it can also be a contaminant in illicit drugs. For example, many years ago when I used to work in California, there were occasional outbreaks of wound botulism among users of black tar heroin because it was being smuggled from Mexico in car tires, so soil would sometimes contaminate the drugs. And because botulism forms spores that are resistant to heat, cooking the heroin doesn't kill the spores. So then when the drug was injected into a low oxygen environment, such as under the skin or into muscle tissue, the spores would germinate and release botulism neurotoxin, causing wound botulism, which can be serious and even fatal. Instead of thinking of exposure only on the individual level, when we zoom out and look at a whole population of people at the same time, cases of disease can be graphed along with time, like we do in an epidemiologic curve when we're doing an outbreak investigation. But histograms like this aren't only for infectious disease. Patterns of exposure are also used in environmental and occupational health. In environmental health, instead of epi curves, we have dose response curves and exposure response curves. These are exposure response curves because the y-axis, which is often labeled rate, is showing the concentration of an agent in the environment over time. It isn't a measure of dose. Studies that do measure dose can test biomarkers, or in some cases, test for the agent itself within the body, or can be done using lab animals, so biologically effective dose can be measured, rather than just exposure. Continuous exposure occurs with uninterrupted contact with a hazard over months or years. For example, the most common source of indoor radon is uranium in the soil or rock under houses. As uranium naturally breaks down, it releases colorless and odorless radon gas, which enters houses through dirt floors, cracks in concrete, and sumps. Long-term exposure increases the risk of lung cancer. Cyclic exposure occurs with repeated, predictable spikes and valleys in exposure that align with routines, seasons, or natural rhythms. For example, when nitrogen oxides from vehicle exhaust and volatile organic compounds are exposed to sunlight and warmth in the air, more so during warm weather, the concentration of ground-level ozone increases, typically peaking in urban areas during evening rush hour traffic. Exposure to ground-level ozone increases the risk of asthma and other health problems. Concentrated exposure occurs with a brief exposure to a high dose of a toxin. For example, inhaling high concentrations of carbon monoxide during a residential furnace failure, which is often caused by a cracked heat exchanger, blocked flue pipe, or incomplete combustion. Like radon, carbon monoxide is odorless and invisible. Intermittent exposure occurs with recurring but irregular short-duration increases in the agent. For example, inhaling wood smoke only when operating a wood-burning stove. Random exposure occurs with unpredictable increases of varying intensities caused by chance events. For example, exposure to trichloroethylene, a synthetic volatile organic compound used as a metal degreaser and in industrial processes to make other chemicals. Trichloroethylene in contaminated soil or groundwater can turn into a gas, migrate upward, and seep into the indoor air of buildings through foundation cracks or pipes. Recognizing patterns of exposure helps environmental health professionals identify likely sources, estimate cumulative exposure over time, and design targeted interventions. The more often the concentration is changing, the more often you need to make environmental measurements. A lot of measurements are needed to capture the true pattern if it's intermittent or another pattern that changes often. So you have to take lots of measurements, otherwise you might miss capturing the true pattern. The toxicological paradigm describes the sequence through which an environmental exposure may ultimately result in disease. Following exposure, only a small portion of the agent reaches the body as the internal dose. Even a smaller fraction reaches the target tissue within the body and produces a biologically effective dose. Early biological changes may then progress to alterations in tissue structure and function before clinical disease becomes apparent. Susceptibility of individuals influences risk at each stage of this pathway, and effect modifiers such as age, nutrition, and co-exposures can increase or decrease the response to an environmental exposure. Briefly, for those who haven't taken epidemiology yet, effect modification occurs when the association between an exposure and an outcome differs depending on the presence of another factor. The combined effect may be greater than expected, which is known as synergism, or less than expected, known as antagonism. Unlike confounding, effect modification represents a true biological or epidemiologic phenomenon and should be identified and reported rather than controlled for. In environmental health, many of the diseases under study have a long latent phase. For example, carcinogenesis often takes decades, up to 40 years is common, which makes it difficult to determine if an exposure may cause cancer because observational research using humans would have to take many, many years. As an example of effect modification using the natural history of disease, in the natural history of cervical cancer, the disease develops over a long period, starting with an HPV infection that triggers precancerous cellular changes. This phase is asymptomatic and lasts for years or even decades, but the changes can be detected with screening tests like pap smears. The clinical phase only begins after the dysplasia progresses to invasive cervical cancer and starts producing symptoms like abnormal bleeding or pelvic pain. If someone gets a co-infection of HIV after they already have HPV, this modifies the effect by accelerating the disease process. Cervical dysplasia will happen sooner, and there's a higher risk of invasive disease. For a variable to be an effect modifier, it needs to be something that could logically modify the effect of the exposure on the outcome. It cannot be on the causal pathway, and there needs to be statistical evidence of effect modification. The effects of exposure to asbestos and exposure to smoking on lung cancer are greater than what would be expected based on the effect of either exposure alone. Both agents, asbestos and cigarettes, produce the response of lung cancer. Co-exposure to smoking and asbestos doesn't produce a risk of cancer 16 times higher. It's much higher than that. It's a synergistic interaction on a multiplicative scale. For carcinogens, there is no safe dose. The y-axis is risk, which is the same as cancer incidence. For agents other than carcinogens, the shape of the curve of health effects changes with each agent. The S-curve here is just an example, but for most environmental exposures, there is a safe dose, represented by the line tracking the x-axis. The dose at which the curve first lifts off the x-axis is the threshold for health effects. Cancer follows a random model, so any dose increases the risk, but not the severity, which isn't intuitive. More exposure to a carcinogen increases the risk of cancer, but doesn't correlate to the size of the tumor. In a deterministic model, we assume there is a safe dose, and severity of response is a function of dose. So for most things, it is possible to regulate to zero risk. But for carcinogens, the best we can do is to regulate to an acceptable level of risk, since no level of exposure is safe. I have a whole lecture on how to determine whether a relationship is causal, so I'm not going to go into a deep dive here, but many of the same methods used in epidemiology for determining causality are also used in environmental health. A congressman argues the sale of the herbicide Roundup to the general public should be restricted because the toxicodynamics of glyphosate, the active ingredient in the original formulation, is not fully understood. This stance demonstrates which of the following. The precautionary principle states that lack of scientific certainty shouldn't delay preventive action. There's enough evidence for concern that the International Agency for Research on Cancer classified glyphosate as a Group 2A probable carcinogen. Another way to think about the toxicological paradigm is that the first three steps relate to toxicokinetics and the last three relate to toxicodynamics. Toxicokinetics is what the body does to the agent, whereas toxicodynamics is what the agent does to the body, or how the agent's active form interacts with the target tissue. In pharmacology, we have pharmacokinetics, which is very similar, and can also be thought of as how the drug moves through the body. What's the difference between internal dose and biologically effective dose? Using a pharmacology example, let's say I have two patients who both had heart valve replacement surgery. I prescribe 5 milligrams warfarin once daily for both of them to prevent blood clots, targeting an INR of 2 to 3. Popeye goes to the farmer's market and gets really excited about all the spinach, which is high in vitamin K, and he overdoes it a bit. Warfarin works by preventing recycling of vitamin K in the body by inhibiting the enzyme that normally recycles it. All that spinach would introduce enough vitamin K to antagonize the effect of warfarin on the vitamin K recycling enzyme, leading to an increase in active clotting factors, so the warfarin wouldn't have its intended effect. When I check the INR of both patients at their next visit, olive oils is within range at 2.5, but Popeye has an INR of 1.2. In this example, INR provides the biologically effective dose, which was different in two individuals who received the same internal dose because of the food-drug interaction with spinach. Similarly, with exposures to environmental agents, individual differences cause variation in each step of the toxicological paradigm, even between individuals with the same exposure. In 60 seconds, see how many environmental health interventions you experience in your daily life, at work, home, or in the community you can name. In risk management, the results of risk assessment are integrated with other considerations to decide whether interventions to reduce risk are needed and whether they're practical. Even if the population attributable risk is high, if there's no safe or practical way to reduce the risk, then that exposure wouldn't be acted on. Risk management isn't based entirely on science. Decision makers also have to consider economics, feasibility, ethics, politics, and community priorities. Environmental contaminants don't recognize national borders. Air pollutants, persistent organic pollutants, heavy metals, and greenhouse gases can be transported across continents through atmospheric and oceanic circulation. As a result, exposures occurring in one region may affect populations far from the original source. Environmental health threats have global consequences.
This lecture introduced environmental health, the 10 essential environmental health services, introduced how we identify and prioritize environmental health issues, risk assessment, and the toxicological paradigm. In environmental health, we focus on intervening at the systems and population levels to prevent disease caused by environmental factors before it occurs.